For the discussion of these cases, we have two experts. Dr. Kamala Ganesh, she is ex-director professor of obstetrics and gynecology from Maulana Azad Medical College. She is involved with IGNU as a regional consultant, and she has been involved in PGDMCH program from the very beginning as a course writer, course editor. And to her right, Professor Manju Puri, she is from Ladihani Medical College. She has been involved with the DNB students. To her right, Dr. Kajila Bhutia, she is representing one of the students, and she will make the case presentation on behalf of the students. To my right, Dr. A.K. Sood, he is Executive Director in the National Board of Examination. Now I will request Dr. Kajila Bhutia to make the presentation, and I will request Dr. Manju Puri to moderate the case. I will also request Dr. Kamala Ganesh to help in the moderation process. Dr. Kajila Bhutia.
I am presenting the case of Mrs. Fetal, wife of Sisupal, 22-year-old female, resident of Kapasera, New Delhi, illiterate, housewife of occupation. My patient is Gravida 3, Para 2, Live Issue 2 with 7 months amenorrhea. Her last menstrual period was 29th of January 2006 with expected date of delivery 5th of November 2006, making her POG 28 weeks by as of today. Came to the casualty of Sachita Kipalini Hospital 15 days back with the chief complaints of breathlessness since 1 week and swelling in bilateral lower limb since 15 days. History of presenting illness. Patient was apparently well 3 weeks back when she started having breathlessness. It was in the beginning it was only on exertion, and now since 1 week it has been increased. She started having even on the daily activities. It was associated with increasing generalized weakness and malaise, not associated with palpitation, chest pain, hemoptysis or syncope.
Why have you taken this history of palpitation, hemoptysis?
I want to rule out if there is any cardiac problems, because cardiac problems also, this breathlessness and bilateral lower limb can be due to any associated cardiac problems. So I want to rule out whether it's due to anemia or cardiac problems. Also the history of hematuria, bleeding per rectum or bleeding from any sides, bleeding from gums or any associated there is no history of burning micturition, no history of chronic cough or fever, and then no history of passage of worms in the stool, no history of easy bruisability, petechiae or hemorrhages, no history of blood transfusion in the past, no history of radiation exposure in the past, no history of any drug intake, no history of jaundice or abdominal mass in the past. And now coming to the antenatal history, detailed antenatal history. In the first trimester, it was a spontaneous conception. It was an unplanned pregnancy.
Before you go for the present history, will you say about the antenatal history? When did she have the first antenatal care? Instead of saying first trimester, if you could tell us first, had she had antenatal care before?
No.
If she didn't have antenatal care, state it now, because that becomes part of the history of present illness when you are giving. We want to know whether she has had any antenatal care before.
There was no antenatal visit. It was an unbooked patient.
Unbooked maybe for the hospital. If she has
not even in the
seen
private
anybody, like even an ANM or a doctor or health visitor, whoever it is, if she has been cared during this pregnancy by anybody, you have to count it as antenatal care.
Coming to again detailed first trimester history, and no history of nausea, vomiting or loss of appetite, no history of spotting or bleeding for vaginum, no history of fever with rash, no history of intake of folic acid and any drug intake or exposure to radiation. In second trimester history, quickening was felt at 4 months amenorrhea, no history again ANC visit, no ultrasound done. Patient received 2 doses of tetanus toxoid at 4 months and the 5 months of amenorrhea respectively at primary health center.
Did she have antenatal checkup done at this point of time?
No. And she just went and got her tetanus toxoid and again no history of pain abdomen, leaking for vaginum or bleeding for vaginum. No history of fever with rash, and then no history of breathlessness, easy fatiguity or malaise. And coming to in third trimester, again, she didn't have any antenatal visit, and at 7 months of amenorrhea, she started having breathlessness and the swelling bilateral lower limb, for which she was presented to our hospital. On obstetric history, my patient is gravida 3, para 2, live issue 2, married for 6 years, cohabiting since then. Her first was full-term normal vaginal delivery of male baby at home 5 years back. Again, second was again full-term normal vaginal delivery, male baby at home 3 years back. Both pregnancy was spontaneous conception, no antenatal visit in the both pregnancy, and no any hematinics taken during the pregnancy and then after the pregnancy, and the liver and purpurum was uneventful in the both pregnancy. Both baby was average weight, cried at birth, breastfed for 8 months. They were both baby was fully immunized, and then no history of contraception used in between the pregnancy and after the pregnancy. And now coming to the menstrual history, patient attained menarche at 16 years of age, and then she had a regular 30-day cycle lasting for 3 days, using 3 to 4 pads for day, no history of passage of clots, and no history of dysmenorrhea.
See, you can't be spending so much of time in giving history while you are presenting in an examination. 20 minutes are given to you for a long case. So you should be able to present. If you say at that time there is no history suggestive of rheumatic heart disease, is good enough. You don't have to say no breathlessness, no pulmonary edema, no hemoptysis and all that. So one line is enough to say that, because you should be able to concise. Otherwise some students keep giving history for 10-15 minutes and there is no time left for asking for the findings, investigations, the management. There is no time left. So one should be very discreet. 6 to 7 minutes we want them to give the history, the relevant history. They can say that there is no relevant history suggestive of rheumatic heart disease is good enough.
And past history not significant, no history of any repeated blood transfusion in the past. Family history again not significant, no history of repeated blood transfusion in the family members. And now coming to personal history, patient is vegetarian by diet, again normal sleep and bowel and bladder habits, no history of addiction.
See, don't say bowel and bladder habit in the personal history. It comes in the present history. That they are like, you have to say about the addictions. You can say vegetarian, non-vegetarians and all in that, but don't give this history.
You can omit this out. It's okay. Yeah.
And the non-smoker, non-alcoholic, no any drug addiction. Patient is living in one room pakka house, belong to lower socioeconomic status according to Kupuswamy scale. And now coming to dietary history, patient consumes around 10,050 kilocalorie per day and the 40 gram of protein, which is her diet is inadequate.
It is 1,000, 10,000?
No, 1,000. 1,000, around 1,060. And now her diet is deficient in both in calories as well as protein.
Now this patient has come with the chief complaints of breathlessness and swelling feet. So what are the different possibilities or provisional diagnosis which will come to your mind in any pregnant patient who is presenting with these two symptoms?
First is we can always think of severe with anemia of different grades. Anemia, next is any cardiac problems, and then third is renal problems. So with according to history or examination we have to differentiate.
So the salient features which you've taken in your history, in the present history, are what as far as this particular case is concerned?
The history to ruling out rheumatic heart disease, as ma'am has already said, and then any bleeding disorders like bleeding from gums, bleeding from any sides, from like, for example hemorrhoids or hematuria, or bleeding bleeding from gums, and then any passage of worms in the stool, worm infestation small, and history of pica.
All right. Go ahead.
And any urinary tract infection?
Yes, ma'am.
Chronic urinary tract
infection, morning maturation, tuberculosis. My patient's height is 150 centimeter. Her weight is 45 kg. Pre-pregnancy weight is not known. Patient is conscious, well oriented to time, place and person, lying propped up, comfortable, not dyspneic at rest. General condition was stable, hydration was adequate, pulse rate was 90 per minute, regular, good volume, right radial, no radiofemoral delay, all peripheral pulses were palpable. BP was 120 by 80 millimeter of mercury, right brachial, in propped up position. Respiratory rate was 20 per minute, regular, thoraco-abdominal. And she was afebrile to touch, facial pallor was present. Clinically, hemoglobin was looking around 3 to 4 gram%. No icterus, no cyanosis, no glossitis, no stomatitis. Orodental hygiene was satisfactory. JVP was not raised, neck vein was engorged, and no thyroid enlargement, no lymph node palpable, and no bony tenderness, no choelinicia, no platinicia, or no clubbing of nails. And now coming to the breast
edema, she had swelling.
Mild pededema was there. On breast examination, bilateral breast was soft, no lump filled, nipple was normal, it wasn't retracted. On coming to systemic examination, on respiratory system examination, on inspection, bilateral chest was moving well with the symmetrically with respiration. A normal vesicular breath sounds was heard, no added sounds heard. On cardiovascular examination, on inspection, no abnormal pulsation seen. Apex bit was filled in the left fifth intercostal space, just medial to mid-clavicular line. No thrill palpable.
You can just say cardiovascular
Vascular system normal.
normal, cardiovascular and respiratory
System normal, and CNS.
You should examine them, but presenting you can say they are normal. So
Central nervous system.
because
normal.
we are not concentrating on that.
Yes,
Okay.
sir. And then now coming to abdominal examination. On inspection, patient abdomen is uniformly distended. Uterus is longitudinal ovoid. Umbilicus is central and everted. Stria gravidorum is seen. No fistula, no sinuses, no dilated veins seen. No visible pulsation seen, and all the hernial sites were free. On palpation, uterus was fundal height was with approximately 28 weeks of period of gestation, and symphysis-fundal height was 26 centimeter, with abdominal girth was 30 inches, and uterus was relaxed, non-tense, non-tender. There was a single fetus with longitudinal lie, cephalic presentation, with back at right, head at brim. Licus seems clinically adequate. FHS was 136 per minute, regular, approximately 5 centimeter from umbilicus in the right spino-umbilical line. No hepatosplenomegaly filled. And now coming to local examination, external genitalia was normal, no discharge per vaginum seen. From the history and the clinical examination, my diagnosis is 22-year-old, gravida 3, para 2, with 2 live baby, with the period of gestation 28 weeks of pregnancy, with single live fetus, in cephalic presentation, with severe anemia, not in failure.
How many times you want hemoglobin tested during pregnancy?
Ma'am, 3 times.
When
First,
you want?
first at the time, first visit, then at 28 to 32 weeks, and at 36 weeks.
Now, can you tell me the reasons for testing it 28 to 32 weeks and the last one around 36 weeks? The reason for that?
Ma'am, in 28 to 32 weeks, because hemodilution is the maximum at the second trimester. And in the 36 weeks, ma'am, we want to know.
And also the increased requirement of iron for the growing fetus is during this period. So the anemia becomes exhibited. It is shown at this time. So you must do that at that time, right?
And at 36 weeks, why do you want to do it?
Ma'am, patient can go anytime in the labor, so we should know the baseline hemoglobin labor, whether cell able to withstand.
Whether the hemoglobin is improved.
Improved or not, even the during labor, during delivery, even the small loss in blood loss, the anemic patient, they don't able to withstand.
So you want to know what is the hemoglobin before
Labor
delivery. Before delivery.
Before
So you are
visit.
doing it around 36 weeks. She can go into labor anytime.
Time.
So you are doing it at that time. Fine. Now, how many antenatal visits you are recommending to your women?
In the till
Means, see, ideally, whatever you are doing, every month and all, every patient cannot come once in a month and all. So, what is the optimum visits that they should make? National guidelines, they say that in the periphery, if the patients cannot come walking such long distances and all, you can cut down the visits at least minimum 4 visits now,
3.
because initially it used to be between 16 and 20 weeks. But now there is one before 12 weeks, so that the pregnancy can be confirmed. The women who do not want to continue with the pregnancy, they don't want the baby, can go for MTP at the right place. You can give the correct advice, and of course the added advantage of earlier the period of gestation can be confirmed much easier in those women who cannot give the exact period of LMP. Exact date of LMP, it becomes easier for them. So the first trimester confirmation of the pregnancy is very important. Now, how will you confirm the pregnancy?
Ma'am, first is per-vaginal examination to see the size of the uterus, and the next thing is ma'am, urine pregnancy test.
I don't want you to do many tests unnecessarily. If you can clinically diagnose the pregnancy which corresponds with the period of amenorrhea, there is no need for any other test. If there is a problem, the size of the uterus is not corresponding, smaller, bigger, so in that case you can ask for a pregnancy test, and if required cases you can also do an ultrasound, no harm. But routinely asking for an ultrasound to confirm pregnancy should not be done. And there is no need for a pregnancy test also to diagnose every normal pregnancy. It should be reserved for patients where you cannot diagnose it. And you shouldn't subject the patient to unnecessary expenses, test for the sake of testing.
I think the clinical examination is most important. So whenever the patient comes to you, I think after the history, it should be your PSPV examination or per-abdominal examination and try to correspond.
If the pregnancy is going to be continued, you have to assess the patient for any other problems, because here is the basic level of basal health of the patient you can estimate at this time. You have to do her blood pressure, you have to take her weight, all those things has to be done like a routine antenatal examination. All the tests should be done so that you have the basal value, and the other findings can be compared to that. So the second visit, when do you want?
24 to 28 weeks.
24 to
That's
28
fine.
weeks.
Very good.
Yes. Third,
And then third is again 34 weeks. We can-
28 to 32 weeks, and the last
First-
visit between 36 to 40 weeks. 2 visits in the third trimester. Now, after the 36 weeks, you want to visit for what reason here? See, the first trimester to confirm pregnancy, unwanted pregnancies, you can tell them to go for NTP, not to go to a unskilled person and get into problems of septic abortion. So the second trimester, you said if we have not taken the BP and all, you can take it here. And the third one, 32 to 40, 20 to 32 weeks, most of the problems starts showing during pregnancy at this period. And 36 to term is mainly for
Ma'am, we can plan the
abnormal presentation to diagnose, because before that the presentations can change. After 36 weeks, the change in presentation is removed. It can happen, but very rare. So most of the presentation you diagnose at 36 weeks is likely to remain. It is mainly at 36 to 40 weeks is for the presentation. In every woman, primary or multi, you want to rule out an abnormal presentation. What investigations will you do first? If the patient is very poor, she cannot get many tests done. If she has to pay for every test, then you must be selective in advising the tests. So what investigations will you ask her to get done?
Ma'am, blood investigation, which include blood group, RS typing, Then complete.
That would have been done in the first visit.
Visit, yes, okay. And then blood group, complete blood count with peripheral smear. Here we can look for hemoglobin to see the degree of anemia. And
would you like to get anything done to see that your hemoglobin estimation has been correct?
Absolutely.
You know, there are many ways of estimating hemoglobin. The most accurate method is sign met hemoglobin method, which is not usually done in the antenatal clinics and all. We do Sally's test. Now, if you prick and you start pressing the finger, then you may get a diluted hemoglobin. So, to confirm that your hemoglobin estimate is correct, if you can get a packed cell volume done, PCV done, that will be very nice.
Ma'am,
So, instead of the blood count, I would rather ask for hemoglobin and PCV.
PCV
And then
peripheral
next best
smear.
is peripheral smear.
smear.
Now, what all information you can gain by seeing the peripheral smear in an anemic woman?
Ma'am, type of anemia, whether it's a microcytic hypochromic or macrocytic or any
Macrocytic?
if ovalocytes
No,
is
no.
in.
Microcytic hypochromic or alone, or macrocytic hypochromic, or only microcytosis alone, any other?
And then parasites for malarial parasites, any immature cells, abnormal cells, evidence of hemolysis,
Evidence of hemolytic anemia, target cells.
target cells, all this anastocytosis, folliculocytosis,
That will be present with any of the anemia. And
target cells, and
infection, what will be the picture?
ma'am, neutrophilia will be there, acute, if it's a
Neutrophilia
DL, so we can see the
multi-lobe
DLs,
cells, toxic granules.
toxic granules in the neutrophils.
So that may be present. So by looking at the peripheral smear, you can get a lot of information. And when the picture is hypochromic microcytic, what is your conclusion?
Iron deficiency anemia
Iron deficiency anemia. It is hypochromic microcytic anemia is due to iron deficiency.
anemia.
Iron deficiency could be due to many reasons. If diet doesn't contain enough iron, there can be problem with absorption. There can be problems in manufacturing of blood. So many problems. But it only shows there is an iron deficiency anemia. The second is hypochromic macrocytic. What does it indicate?
So the other name of this is dimorphic.
dimorphic.
Now, dimorphic anemia, the prognosis is much worse if not treated, even more than the iron deficiency anemia, because there are multiple deficiencies here. Indices cannot be done in a periphery. If you have to do it yourself, if you have to do the test yourself, what else will you do?
Urine routine microscopy
Routine
to see for
microscopy.
the any
You will do a routine examination of albumin, sugar and microscopic.
and
If the microscopic picture shows more pus cells, what you consider it as normal picture? Means above which you will consider it as abnormal.
more than 10 pus cells.
See, more than 5 to 6 pus cells per hypophil in an uncentrifuged specimen.
Okay.
Because you cannot do the centrifuge in a very remote place and all. So take a drop of urine, see if there are more than 5 to 6 pus cells, send it for culture. Okay? Okay. Otherwise culture is not required. What other investigations?
And ma'am, ova for a stool for ova cyst,
Ovasis.
and then occult again blood
Occult
or
blood.
RBC.
Occult blood is
important.
a good test to do, easy to do. I want you to tell me test which you want to do. You said you want to do the blood indices. Okay, do blood indices. What will they tell you? What information does the blood indices give you?
Like for ma'am, PCV, hematocrit, usually normally
Hematocrit, I said we will do it. We can
As
do
a
it
first
in
line.
routine to confirm the hemoglobin.
and then like ma'am MCV like ma'am, if it's increased then we can say it's a megaloblastic anemia. If it's decreased then microcytic anemia, and then if it's normocytic normochromic anemia,
much
and
more
then
important
according
that indices can be done, no problem. But if you have to do 1 or 2 tests only,
Then which test?
you have already seen in the peripheral smear. Any other thing you can do which will give you a good picture? Serum ferritin you would like to do. I allow one more test for you.
No, other than serum ferritin, any other one more test if she is allowed. Which test would you like to do which will give you maximum information?
See, each test should give you the either it gives a very specific information regarding your management or give you maximum information. So one more test if you have to do, what will you do? Bone marrow biopsy is the
It's
last
only,
one.
yeah.
Is the last one.
Yeah, there's certain ma'am.
You can do the
there's indication.
serum binding globulin level. So it will give you some idea. Now tell me, since you said bone marrow, when the anemia, when the woman starts iron deficiency, what are the first things to be affected in the body? Then comes in the second thing and the third thing to show up. If you want to diagnose anemia at its earliest, what test will you do?
Before the blood changes appear.
Before even the blood changes appear,
So what is first to be affected?
Serum ferritin level. First thing to be affected.
first thing to be affected is, as long as there is iron in the bone marrow, serum ferritin level can be normal, because it will keep drawing from the bone
Iron
marrow.
level in the bone
So
marrow.
first thing is bone marrow. We don't do that test very often, only in very rare cases. Second, the blood level of serum ferritin and all, and lastly the hemoglobin.
And any other investigation? This is as far as the mother is concerned. Would you like to look up anything else?
And then ultrasonography. If again facility available to confirm
For what?
my period of fetal maturity,
No, no.
like
When would you like to do it for? If she couldn't give a correct picture, when is the best time to get the ultrasonography for
Fetal
dating.
maturity.
fetal
dating.
maturity?
Yeah.
The ma'am first trimester, then again at the 16 weeks.
See, people don't have that much money to get it done at first trimester
Ma'am,
and again at
16 weeks. The best is 16 to 20 weeks.
16 to 20 weeks, if you don't know the maturity, if everything is fine. Okay. At this time, fetal maturity 26, 28 weeks, is it going to give you any information which is going to help you in deciding the maturity? Can you assess the maturity very accurately at this time?
By ultrasonography, ma'am.
Ultrasonography. Does it help you? She knows her LMP. You have clinically assessed her. Does it correspond to the period of amenorrhea? It corresponds to the period of amenorrhea. So why do you want to confirm maturity and get the things done and all? Now, since you couldn't do a ultrasound at 16 to 20 weeks,
Yeah,
you can
to
do
rule out
one ultrasound to rule out
GCA, gross congenital anomalies.
gross congenital anomalies. That is the advantage you can
advantage.
have by doing it at this time, otherwise there is no other advantage. This also, nobody should refuse a patient that I won't look after you if you don't get an ultrasound done, is a wrong, it is not the right thing to do by the doctor. If she can afford it, okay, by all means get the ultrasound done. If she cannot afford it, even without ultrasound we can go ahead, only warn her that there could be a congenital malformation and she shouldn't get upset by it. It doesn't matter if she cannot afford it, it's all right.
What is important is that ultrasound should be helping you in managing the patient, but it is not mandatory. And so a large number of conditions can be picked up on clinical examination, and one should continue giving right care to the patient without actually depending upon ultrasound to help you diagnose
Okay,
conditions.
now what will you do? She is 26 weeks, 28 weeks. How are you going to manage this patient now?
According to type of anemia and degree of anemia.
See,
For example,
anemia
it's a-
picture was hypochromic
Chronic
microcytic
microcytic.
anemia.
Ma'am, if the
And the
hemoglobin
hemoglobin is
level is
3
less
gram
than
percent.
3 gram percent, I like to give a blood transfusion so that her
Okay,
hemoglobin
now-
level comes to at least 5 to 6 gram percent.
No, I want to know that if you are going to give blood, you can give 2-3 things, either you can give whole blood,
Or
you can
packed
give
cells.
packed cell,
Packed
you can do
cells.
an exchange transfusion. So what are you going to do? When will you give packed cell? When will you give whole blood? And when will you do an exchange transfusion?
Severe anemia usually give a pack cells because we don't want to overload the patient.
I would say, you said your patient is hyperproteinemia also. She needs the proteins in the serum also. I would put it, you can give whole blood
Under Lasix cover.
if she is not on the verge of failure. But so what will be the sign which will tell you that she is not on the verge of failure and you can get away with a whole blood transfusion?
Patients with it's palpitation, dyspneic, like in the decompensating.
Any signs on
Sign.
examination?
If patient has no tachycardia,
No tachypnea,
Okay.
and then bilateral chest clear.
if the chest is clear,
Clear.
there is no JVP
Be
raised,
raised,
you
no.
can give whole blood
Blood.
transfusion.
But I would still prefer in case back
No,
cells
you
are
can
given.
give a whole
Un-
blood
Under Lasix
after,
cover?
yes, Lasix cover, give her a Lasix before you start the blood transfusion, an hour before, let her pass some of the, lose some of the fluids from her body, then give, because that additional protein is also going to
Other
help
co-
her.
Yes, ma'am.
So you can give her. But if she is on the verge of failure, you have to again give her a Lasix. You give,
Lasix, then blood transfusion.
then you can
Post-
give
blood transfusion.
Paxil
Yeah.
if she is again on the verge of failure and all those things. And if the woman is in actual congestive heart failure,
Yeah.
In that case,
what will be the signs of congestive heart failure then?
Again, the patient will be tachypnea, bilateral JVP will be raised,
Yeah.
bilateral chest crepes will be there,
Yeah.
and pedal edema will be there, and
And one more.
hepatomegaly. That is the right side.
See, hepatomegaly may be
It's
difficult to make out in late pregnancy, but tenderness in the right
Right
hypochondrium will tell you that the woman is in failure.
Yeah.
So, in those cases, you can give an exchange transfusion.
what is the final line of management? How many blood transfusions would you like to give her, and then put her on what kind of treatment?
At least I want to bring her up hemoglobin up to at least 5 to 6 gram percent. So if a patient is 3 gram percent, then I would like to give at least 2 to 3 unit of blood transfusion, because 1 unit of blood increases the hemoglobin by 1 gram percent. So after that, I would like to put the patient on the oral preparations, and then in the hospital setup nowadays 100 milligram of elemental iron with 500 microgram of folic acid preparations is coming. So we can I like to put on 1 BD, total of 200 milligram, and the 1000 microgram of folic acid, and see further, and then also the high protein diet. This patient's nutrition is inadequate, so I would like to educate nutrition, high protein diet with monitoring, repeat the again hemoglobin and the peripheral smear after 1 week to see the response.
Why have you decided to put her on oral? What are the indications of putting the patient on parenteral therapy?
If patient's compliance, if patient is not willing to take orally, and the side effects, and also if there is some associated malabsorption problem like irritable bowel disease, or and then ongoing some chronic infections or chronic blood loss, then I would like to put in the parenteral therapy.
Why have you decided to put this patient on oral and not parenteral? This particular patient of yours.
Yeah, because the patient is less than 30 weeks. So we have ample of time to build up the hemoglobin. So I would like to put on the oral hematinics.
Alright. Now, you told me that you would put her on parenteral in case she's got chronic infection.
Infections.
Do you think in the presence of chronic infection, oral or parenteral would have any difference?
No, but if it's not responding to oral hematinics, even after 4 to 6 weeks, we'll see. Even after 4 to 6 weeks also, if patient is not responding, then obviously treat the underlying infections.
Or you will have to give more blood transfusions in these patients. Because if they are not responding to oral iron, they may not respond to parenteral also. Is it right?
Yeah.
Now, when you give oral iron to the patient, now what are the instructions which you would give to the patient?
How do you know, assess the response that this patient is going to respond to oral iron or parenteral iron? What will be the indicator which tells you that this patient is responding to your therapy?
First thing, to increase reticulocytosis by 3 to 4 days, and then hemoglobin will rise by 1 week, 8 gram per 0.8 gram
Not
per
by
deciliter.
1 week. The hemoglobin rise starts showing by about 3 weeks. Then at the rate of 0.8 to 1 gram per week,
Per week.
it will rise. So these two will tell you response is there or not there.
If you have to assess whether your patient is actually taking medicine or not, how do you assess that?
Ask for the color of the stool.
Yeah.
If she's taking this iron, she'll have a black colored stool, dark colored stool.
Right.
The last question I want to ask you is, when you are prescribing iron tablet to a patient, what instruction will you give her at the time when the patient, you are talking to the patient, and what counseling will you do when she's taking iron tablets? Counseling with regard to iron tablets.
It's taken between the meals, and then like taking associated antacid
Which is
has
the
to
best time to take iron?
Ma'am, before the meals, but empty stomach, but side
So what
effects
will
is
you
very
tell her?
high.
You can tell her that you can start taking it before the meals, but if you find there is a problem,
Then it can
take between the meals
Meals.
or after the meals,
meals.
whichever suits you.
Drugs like antacids, proton pump inhibitors, H2 blockers has to be avoided, and also the iron, calcium should not be taken along with the iron tablets.
How will you ensure that the iron absorption is increased from the diet or from the tablets? Iron are absorbed.
Ma'am, vitamin C.
So
Vitamin
you can
C.
say that with the diet she can take
Take
vitamin C
rich-
containing foods,
rich
like lemon,
lemon and
amla, the other things which contains extra vitamins. She has to take that. What else? You said milk or
calcium.
other things should be avoided, which hampers
also
the
with the
absorption.
absorption.
What other things should you say?
Ma'am,
What other things hampers the absorption?
like ma'am, tannins in the tea,
Yes.
So
and then phytates. in
tea
the
and
bun.
coffee should not be taken
along.
1 hour before and 1 hour after the iron tablet. Now, one more instruction I would like you to tell the patient. You know, many a time patients do not come back to us. They say, "Humko mafik nahi aaya." That means they don't get adjusted to the iron tablet. So they don't come. So you tell them, if you cannot take the iron tablets, either before, during, after, nothing, if you cannot tolerate the iron tablets, come back to me. I may have to give you something else. You may change the tablet, you may give parenteral iron for her, but something has to be done. Such patients should not get left out. Then coming 3-4 months later with severe anemia, that is not right. So you have to tell them, even if you can't take it, come back and tell me that you cannot tolerate the tablet. I'll change the tablet, or I'll give you injectable iron. So you have to have iron.